So I'll just kind of, now that we are recording, we plan to have this Zoom session today where we'll finish off vestibular testing and the inner ear disorders. We'll go into retrocochlear pathology and get as far as we can in that. And then tomorrow, Wednesday, July 19 at 9:30, I mean at 11:30 Central Time, same time as now, I'll finish off whatever we don't finish trocochlear pathology today, and we'll complete the smaller topic of pseudohypoacusis, malingering, lying. And that will complete our hearing disorders course. All right, as far as I'm concerned, I'm in charge of Zoom sessions and giving and grading exams. Ms. Royer does everything else. She does the admin stuff and all of that, I don't know, the discussion groups and whatever else, but my stuff is always Zoom sessions. So at any rate, why don't we cut into it and start out with good old vestibular testing and finish that puppy off. Are we good? All right. Share the screen today, yeah, and we find the one we want. We don't have any real PowerPoint on the vestibular system. All I'm showing you in this PowerPoint that you see on the screen in front of you is actually from anatomy. I just pulled this out of anatomy. It's not on Blackboard under disorders, but I'm not going to go into it much. I'm just showing you here the semicircular canals. I'll just pull that guy up here because we're looking at the balance organs now. Okay, the not the cochlea. Well, we're looking here, and you've got three parts in your balance system. One part is the utricle. Next part is your saccule. And that's why they're showing you here. Saccule, utricle. Look at it in your anatomy notes. I'm not going to quiz anyone on the anatomy at all. I'm just showing you this so we have a better understanding of it. And the third part is the three semicircular canals. And what's interesting about the semicircular canals is that they are complete right angles to each other. Like my hand here, thump, thunk, and then a floor. It's like a corner of a room. Look at the corner of your room where you see the two walls meet and the floor. They call that orthogonal planes. Orthogonal, O-R-T-H-O-N, orthogonal planes. They meet at 90-degree angles. Perfectly, 90 degrees. And so that means, okay, now in just one little sentence here, the utricle and saccule tell you whether you've gone this way or that way, and when you've gone up and down. One's for up and down, the other one's for horizontal. I don't even know which one, so I'm not going to ask you, okay? All I need to know, when you're on an elevator and you go up and all of a sudden your stomach goes, that's your utricle and saccule, okay? When you're sitting in a car and you've got your foot on the brake and the person beside you is moving, you are thinking you're going backwards and you're not. That's the utricle and saccule playing around with your eyes. Okay? Your balance system has three parts to it. All right, and I'm going to stop sharing here and really highlight this. Balance is a really complicated sense. Yeah, we won't even get into it here. I'll just suffice to say this. It deals with vision. That's one part. The vestibular system of the ear with its three parts, the utricle, saccule, and semicircular canals, okay? That's the second part. So vision is one part. Your vestibular system, which has three parts, is the second part. And the third part of balance system is called proprioception. P-R-O, prio, P-R-I-O. So proprioception, C-E-P-T-I-O-N, proprioception. Now, proprioception is almost humorous. This is like, how do you tell where your limbs are in space without you knowing, without you looking? How do you know where you are in space without yourself looking? If a cop pulls you over for DUI, She's going to have you stand outside the car. You'll be standing, and she's going to say, okay, now close your eyes, put your arm out to your side, close your eyes, and touch your nose. That's proprioception. If you're drunk, you're going to do this shit. You're going to miss. Okay? You will have poor proprioception, knowledge of where your limbs are in space without you looking at them. So balance, vision, vestibular system, proprioception. All right? And that's how you break down balance. So if a person's got bad vestibular system, that person's going to be relying on his eyes more. So that person's going to have big trouble at night. Big time. Because he can't see very well. And now his stool's only got one leg. Proprioception. Okay? Because the balance organs aren't good. And the eyes, he can't use that because it's nighttime. You see what I'm saying?
Proprioception, is that in the brain then, or?
It's in your muscles. Actually, thank you. That's a very good question, Kelly. It's in your muscles.
Muscles.
In your muscles, believe it or not, your muscles have all these fibers in them, and in each muscle, one of the fibers is called intrafusal. Don't get in. Just don't worry about it. But it's in your muscles. Okay, so balance system is really wild. I mean, it's like, anyway, I'll share a screen, and we'll look at we'll look at a piece of the. We'll look at. Let's see if I can hit escape here. Sometimes it gets fussy on me. Sometimes pull up notes here and look at your good old, inner ear disorders. And we'll scroll all the way down to good old balance system, vestibular system, all the way down here. We go down, cochlear dead, vestibular. Here you go. Have a look. Gives brain information regarding position of body in space. And here it is right in your notes. Human balance system is comprised of 3 parts. Vestibular system, vision, proprioception. You'd think I wrote this. Huh. Anyway, vestibule, entry into the bony labyrinth, contains the utricle and saccule, 2 of the 3 organs of balance. The vestibular system consists of the utricle, saccule, and the semicircular canals. Utricle, leather bag, saccule, little sac. They contain endolymph, just like the scala media does. They have hair cells, just like the scala media does. They don't have inner and outer hair cells. They have what's called type 1 and type 2. Doesn't matter, don't worry about it, but type 1 sends info to the brain. Type 2 is like the outer hair cells, takes info from the brain. Okay, just like the cochlea. It has perilymph. It's got endolymph. Anyway, the purpose of the utricle and saccule is to tell you linear acceleration, horizontal or up and down. The purpose of your 3 semicircular canals, that's different. The 3 semicircular canals are for your head. Your head is a weird part of your body. Look at an elbow. It just bends in one direction. I can't bend an elbow sideways. If I do, it's going to snap. It's a hinge joint. Look at a knee, okay? You're looking at a knee. It only bends one way, okay? You're looking at a head. Your head goes anyway. Your head is it's all over the place. Your 3 semicircular canals, because they are orthogonal planes, 90-degree angles to each other, no matter which way I move my head, fluid is going to move in one or more of those 3 semicircular canals. Hair cells are going to be stimulated by the movement of fluid in one or more of those semicircular canals. Why? Because they are at 90-degree angles to each other. They are orthogonal. It means any which way I turn my head, it's going to stimulate hair cells. That's why you have semicircular canals. Location of your head in space. Okay? Weird, but that's balance for you. So, now we share the screen again and we look a little bit at the notes. And basically, don't memorize this stuff. This is just inner ear disorders. You can look at the stuff, but don't freak about it. I just mainly want you to break down The fact that balance has three parts: eyes, vestibular system, proprioception. And now when you take away proprioception and you take away the eyes, you're left with the vestibular system. And you can look at the vestibular system as having three parts: utricle, saccule, semicircular canals. Okay, that's the breakdown. You need to know that they have hair cells, just like the cochlea does. Stuff like that. That's it, okay? I'll just show you a couple of pictures from your good old anatomy course. Excuse me. And this is showing you all the hair cell areas of your whole ear. Cochlea, saccule, utricle, and look at the hair cells in your semicircular canals. They are just in the bulbs. They're just in the bulbs. They're not in the big round parts. They're just in the bulbs. Just FYI. I don't know, just...
Autotoxic drugs that affect the
Yes.
vestibular system?
Yes.
They affect the hair cells? Is that
Yes.
is that what they affect?
Yep, correct. Exactly like what would happen in the cochlea.
In the cochlea?
Yep, streptomycin tends to affect balance as well as hearing.
That's what my stepdad was given for knee replacement, and years didn't know why his balance was bad.
Yeah, no kidding. Like doctors are learning. Mm-hmm. This is what it looks like inside of one of the in one of your balance organs. Look at the hair cells, and they've got this gelatinous mass. See that? Unlike the cochlea, in the balance system, gelatinous mass, like jello, covers the hairs of the hair cells. And then look at the top. There's these little stones. And you're going to have clients talking to you about their ear stones. Okay? The stones fell off. My ear stones fell off. And that means that these little stones fell off the gelatin. And that happens in the semicircular canals. And in the utricle and saccule. And when that happens, the person gets something called benign paroxysmal vertigo. Let's go into your notes and get straight to the heart of the matter here. Okay? Look at the bottom of your page. BPV, benign paroxysmal vertigo. It is the most common balance disorder. BPV. I'm getting BPV, okay? It's benign, meaning it's not cancerous, you're not going to die, it's just a nuisance. Think about it this way. Someone's going to tie his shoe. I'll stop sharing for a second. Someone's going to tie his shoe, and he's bending down to tie his shoe, and all of a sudden, whoa, whoa, you've moved your head in one certain direction, and whoa, the room's just going nuts. You're hanging on. Oh, and then every time I get in that one position, it kicks it off. BPV. The treatment for it, some audiologists are trained in this, and it's called head positional things. They lay you back on a bed and have your head hanging back off of the bed, and they turn your head this way, or they'll turn your head that way, and then have you sit up with your head turned, and it's meant to reposition the stones back on the gelatin again. So vestibular experts learn how to do positional movements to realign the stones so they lay back on the gelatin again. So it's the most common vestibular disorder, BPV.
Do they use an ENG to diagnose that, or
that's exactly correct. That's right where we are going. So you're bang on the money here. So why don't we just scroll down, keep going there. There we go. Let's see. Oh, that's it. Yeah, there it is at the bottom. Electronystagmography, ENG. Electronystagmography. Now, nystagmus. That word means, it's Greek for drowsiness. I'll stop sharing. Nystagmus. Your eyes. Okay, think of yourself, you're at a road and there's a train passing you. So you got to stop for the train. And the train cars are going in front of you. And you're counting the cars. What are your eyes doing when you're counting the train cars? They're going like this. Because you're counting. 1, 2, 3. That's nystagmus. That's your eye movements. When they're doing electronystagmography, ENG, they're putting electrodes right on the sides of your eyes. And then they're having lights move in a certain direction, and they're tracking your eyes. Then they put cold water in your ear canal. Get this, they call that calorics. I think it's 6 degrees below 98.6, and your eyes will whoa, because you're trying to keep balance. It's going to throw you off of balance because it's right near your semicircular canals. They're putting cold water in your ear canal. It's bugging one of your semicircular canals, and it's making you think, oh, you're dizzy. Oh, shoot, I'm dizzy. And so your eyes are tracking. You're trying to keep up balance, and you're getting nystagmus. Good, that's normal. They want that. Now they put water in that's 6 degrees above 98.6, and your eyes should be tracking exactly the opposite way. And they go, good, you're normal. That means your vestibular system is working. If you don't get nystagmus, you have vestibular weakness, and that's BPV. You've got a problem. Okay? So they do electronystagmography to diagnose BPV, benign paroxysmal vertigo. And they do that by putting electrodes on your eyes and watching to see how you get nystagmus when they bug your semicircular canals with water or air that's above and then below your blood temperature. There's people, audiologists take a whole course in this, vestibular testing. I hated it. I couldn't stand the course. Oh, God, what a mess. You got this water flushing out, and you got this paper coming out with all these eye tracking movements, and it's like, oh, I think I'd rather fit hearing aids. I don't know. A lot of people opt to have technicians do this. Ear, nose, and throat doctors will just hire a tech to do this. A few audiologists actually open up and do vestibular testing, like as part of their, but very few. There's not a lot. I'm going to say 95% of audiologists don't do vestibular testing.
In Boise, there's only one ENG, VNG testing in the whole Treasure Valley, and my stepdad's having to wait a month to get it done.
Yeah.
So he's a little frustrated. He goes, that's crazy. There's only one in the whole area, you know.
That's because hearing loss is common, vestibular problems. And the funny thing is, your vestibular system begins in gestation. When a mother's pregnant, the baby's balance system forms first. Then hearing does.
Oh.
So balance is the primitive sense. Evolutionarily, it's early. You have to have balance to live. You can't live without balance. Hearing is a luxury sense that's built on top of balance. Okay? You can think of speech that way too. Your vocal folds, your larynx. We use it to speak, but its more primitive use is to go number 2. Is to lift heavy boxes. Is to bear children, because that's what it's for. It's to help you lift heavy things. It's to help a mother deliver a child. It's to help people have bowel movements. That's what it's for. That's why you have it. We build speech on top of it. It's a basic sense, and then speech is built on top, is an overlaid function. Isn't that weird? And hearing is too. It's overlaid on top of balance. Balance begins earlier in utero, and then hearing later starts. There you go. Didn't you learn that in anatomy in good old 120? Anyway, you did here. Okay, that's vestibular system. That's all we're testing. We'll just move on now to retrocochlear pathology. But we can't get out of a disorders course unless we've covered at least that basic area of vestibular system. All righty. Now we shall go to good old retrocochlear pathology. I'll close this particular guy here. I can close that one, and we will go to this guy. Retrocochlear pathology. Have a read with me. Retrocochlear. This is where you refer to a physician or to an audiologist. The HIS does not deal with retrocochlear pathology. Our job is to recognize it as a red flag. And when we see it as a red flag, we need to know the signs and symptoms. Now, signs are seen, okay? Signs are actually, if someone's balance problems, that's a sign. You can actually see it, the person stumbling. Symptoms are reported. So tinnitus is a symptom because you can't see the tinnitus. You only have the person reporting it. The person saying, I've got ringing in my ear. Okay, so you always break things down that way. But retrocochlear pathology and nerve terms. Retro, as we all know, means in the past. Hey man, cool lampshade, man. Ever retro? Retro means behind the cochlea. So retrocochlear pathology means eighth nerve and everything else, brain stem and brain. Okay, so let's break a few things down. What is your central nervous system? Your central nervous system is your brain and spinal cord. In a way, you can think of the brain as having a tail that goes all the way down to your ear. Okay, the spinal cord is part of your central nervous system. When you think of central nervous system, it is, I'll stop sharing here. You know that we say that afferent information goes to your brain, efferent goes out. Well, central nervous system is where afferent ends and efferent begins. It's the central station. Now, if I have my hand on a hot stove, I touch a really hot cup and I pull my hand away, that's a reflex. A reflex means an afferent message of pain went to my spinal cord, and then a message to pull away came to my muscles. I never thought about it. The message never went to my brain. No time for that. I didn't sit there and go, I should probably remove my hand or my skin will burn, so I will probably lift my hand now from the stove. It's a reflex. You just, so that message went to your central nervous system, which was your spinal cord only, and back out to your muscles. Same with your acoustic reflex. When you think of the acoustic reflex, a loud sound in one ear causes the little muscles to pull in your ears. That message never went to your brain. It went to your brain stem. And your brain stem is simply your spinal cord in your skull. Your brain stem is simply your spinal cord in your skull. That's all it is. Okay? Very, very important to have that broken down. And when you're looking at now at the brain and brain stem, okay, and we'll take a peek-see here. I'm going to go down over to this slide here. Here's a picture of your brain. I'm going to blow this guy up here. Here's a picture of a brain. And this is a sagittal cut of a brain. We're slicing the brain right down the middle, and you're turning it sideways so you can look at it. The largest part of your brain is your cerebrum. That's your cortex, the wrinkled stuff. Now, the cortex is gray. Okay, it's gray in color. Underneath the cortex, you'll see this big white thing here. And that big white thing is called and that's white, that's your corpus callosum. Corpus means body. Callus means hard, calluses. Corpus callosum. When anatomists put their fingers down the fissure of your brain, their fingers would hit a hard body. And that hard body was this, where my cursor is, right there. Below your corpus callosum is your thalamus. Now, right where I'm circling here, your thalamus is your grand central station for all sensory input. Touch, vision, hearing, taste, okay? Every sense except smell. We don't know how smell works. We just don't get smell. Smell is somehow related to memory. You know, when you smell some bread and it just takes you back. Smell is a very primitive sense, and it's innately tied with the very primitive areas of your brain involving memory and stuff. Anyway, that's your thalamus. If you go below your thalamus, now you're at the brain stem. Now where my cursor's drawing, the brain stem has 3 areas. The midbrain is right where I'm circling here. The midbrain is where eyes and ear information meets. Eyes and ears. The pons, this big bulb here, okay, that's where a couple of other hearing areas are located. You have several different way stations. They're called nuclei. See how this brainstem is white? Inside, it has gray areas. Okay, and the gray areas are various areas of hearing, various areas of vision, various areas of all kinds of things. The 8th nerve ends right there at that point. The ponto, and this is because they call this the pons, and the bottom is called the medulla, M-E-D-U-L-L-A, medulla. Medulla, pons, midbrain. Medulla, pons, midbrain. And then below the medulla, well, now you're leaving the skull and you're going into the spinal cord. So this is all in your skull. They call it sagittal view, which means sliced down the center this way. Okay? All right. There's the back of the brainstem. Here's the front of the brainstem. Look at the front of the brainstem. You got how many pairs of nerves hit your brainstem? 12. You have 12 pairs of cranial nerves. And the 8th nerve is the 8th pair. Let's look where it is. Right here. 8th nerve. Okay. We're at the pons and the medulla. These are all other nerves, optic nerves and glossopharyngeal nerve and blah blah nerve. And I think this is the 7th facial nerve. This is the 8th nerve. This is the trigeminal nerve, whatever. They're all just these pairs. And if you counted them closely, you get 12 pairs. Okay? Now, here's a question for you. Those are called cranial nerves because they're inside your skull. And where do they end? At the brain stem, either at the medulla, pons, or at the midbrain. Okay? Cool. We're good. Now, here's a little quiz question. Cranial nerves, are they part of the central nervous system or not? Your 8th cranial nerve, if I asked you on a quiz or on a test, on a true-false, the 8th cranial nerve is part of the central nervous system, true or false? Megan has it correct, it's false. Why? Because it's not the brain, it's not the spinal cord, and it's not the brain. Only the brain and the spinal cord is the central nervous system. Doesn't matter if the 8th nerve is in the skull, doesn't matter. Okay? It's not the brain and it's not the spinal cord. Ergo, it's part of the peripheral nervous system. CNS, central nervous system. PNS, peripheral nervous system. Cool. All right, and you have that, of course, written right in the notes. So we'll just kind of look at these notes here for a second and see if I can escape this here. Go to the notes and you will see it there. Retrocochlear, central nervous system, peripheral nervous system. Okay, and there it is. And look at the last sentence there. Note, 8th nerve is inside skull, but still part of peripheral nervous system. Now you've got, look below that, you're going to see 4 words. In your notes, you'll see nerves, ganglia, tracts, and nuclei. Now, what the Sam Hill? People always talk about nerves. Well, guess what? You have 4 different things happening here. Nerves are white matter in the peripheral nervous system. Ganglia are gray matter in the peripheral nervous system. Now, let's just stop for a second here. And because I'm not teaching anatomy, I don't know, so we'll just talk in English, okay? Think of a nerve as your arm, okay? And we'll say that the cell body is my elbow. That's we're going to call that, and if that were the 8th nerve, that would be the spiral ganglia, all those little cells, the cell bodies of the 8th nerve. And then you're going to think of the nerve as having an arm. And that arm inside is gray. Think of your bones as going to be gray, okay? The outside is covered with flesh. That's the white matter. And the white matter on a nerve actually looks like hot dog buns. It's beep, beep. It looks like a series of hot dog buns. Blip, 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 blip. White matter is fat. It's lipids. It's fat. And when you're getting multiple sclerosis, you are losing white matter. You are losing that. That's the insulation around your nerves. It's like losing the wrapper around electrical wires. So now you got the wires themselves touching each other. You're gonna get shorts. Okay? White matter is fat, and it covers the gray areas. All right. The gray areas is the cell body. So when you think of the eighth nerve, okay, I'll sort of stand back a little bit. Think of the eighth body. The eighth nerve is having a cell body and two arms. One arm goes to the inner hair cells. The other arm goes to the brainstem. So the eighth nerve is bipolar. It doesn't mean it's really depressed and really happy, okay? That's a mental condition, being bipolar. But it's bipolar because it has a cell body and two arms. And all sensory nerves are like that. They're all bipolar. They have a cell body and two arms. In your eyes, okay, the optic, the retina, the nerves on your retina, bipolar, okay? Now, bipolar nerves are called sensory nerves. Sensory, because they are mainly afferent. They send info to the brain. Sensory information is afferent, right? I mean, say vision goes to your brain, hearing goes to your brain, taste goes to your brain. So sensory nerves are always bipolar. They've got gray matter and they have white matter. I saw Deborah. There was a woman, someone tuned in named Deborah, and all of a sudden she was gone. I should have said, hey, stay, but she left. Anyway, okay, so sensory, they have, sensory nerves have white matter on the arms, gray matter is the cell body, and also gray matter inside the arms. So when you think of and now I got to give you an analogy. Let's go to the central nervous system. In the central nervous system, you have gray matter and white matter as well. Okay, same thing. Now back to the nerves again. Motor nerves, motor, not sensory, motor. Motor nerves are efferent. Motor means it went from your brain or spinal cord to your muscles. So that message went from brain out to my body. So motor neurons, muscles, that's an efferent system. Sensory is afferent. And efferent nerves aren't bipolar. They don't have a cell body and two arms. They've got a cell body, and like an octopus, they've got lots of arms. They have one long arm and a bunch of little ones. Those are motor neurons. They have one long arm and lots of wee little ones surrounding the cell body, just like little hands, and then one long one, motor nerves. They also have gray matter and white matter. All right, stop sharing screen, back to the notes here, coffee break's over, back on your heads. Now look over here, look at these four words. Nerves, white matter in the peripheral nervous system, e.g. eighth nerve. Ganglia, gray matter in the peripheral nervous system. For example, spiral ganglia of the cochlea. Then you'll see two other words, tracts and nuclei. Tracts are white matter in the central nervous system. For example, the corpus callosum. Okay, nuclei, gray matter in the central nervous system. For example, cochlear nuclei of the brainstem, or superior olives of the brainstem, or your cortex, gray area. And you want to get really strange, I could go to the fridge and grab some broccoli or cauliflower. If you want to really think of the brain, grab a piece of cauliflower or broccoli and look at how all the florets on the top, all the bumpy stuff, the good parts. And then underneath is the stalks. The stalks, white matter. The florets, gray matter. So you think about that as your brain. Okay, the wrinkly cortex is the outside of the broccoli or cauliflower, and if you cut into it, you'll see these the stalks. That's the white matter, and that's going into your brain stem and down into your spinal cord. And that's all white matter covered with fat. Okay, kind of strange, but I'll show you a picture of your spinal cord, and it's really kind of weird. Let's see if I can find that guy right over here. Look at this. Here's a spinal cord. Here's a picture of just a section of a spinal cord. See how it's gray on the inside and white on the outside? As the brain is exactly the other way around. It's the stalks of the cauliflower, the white, are on the inside, and the gray is on the outside. So somehow behind the brainstem, everything changes. It inverts. Oh, well, just FYI. All righty, but this isn't an anatomy class, so I'm not going to be, we need to talk about disorders. So basically, look at the 8th nerve. It's the shortest of all your cranial nerves. And it says right above that, too, it's a bipolar nerve. Motor nerves are multipolar, so this is all in your notes, okay? Your 8th nerve is only 1 inch long. Guess how long your brainstem is? 1 inch. 1 inch, 1 inch. We're talking small, everything's small. How thick is your brainstem? About like your pinky. Cut it and you're dead. everything goes there. Retrocochlear pathology. Main sign is unilateral sensory neural loss. Let's look at the pictures. We'll take this home. Look at the 8th nerve, how it's coiled like a rope. See that? Here's your scala media. And all the fibers of the 8th nerve, they come from the inner hair cells, and they're coiled like a rope. So your 8th nerve also is tonotopic. Can you see where the low frequency fibers of the 8th nerve are? They're on the inside, aren't they? Here's the apex of the cochlea. Look at how the fibers would be on the inside. And here's the high frequency areas of the cochlea near the base, and see how the 8th nerve fibers there are on the outside. How many inner hair cells do you have in each cochlea? 3,000. How many 8th nerve fibers to each inner hair cell? 10. How many fibers then do you have in the 8th nerve? 30,000. So always think of a nerve, the 8th nerve, it's a bundle. Much like a rope is comprised of many fibers. Many nerves are like that, okay? They have lots of little neuron fibers to them. Here's a picture of an 8th nerve tumor starting to grow. It's right over on the right here, okay? This is your external auditory meatus. This tunnel here is your internal auditory meatus. And now when the 8th nerve leaves that tunnel, because this tunnel is bone, right, solid bone, and then the tumor can't grow much in there because bone is surrounding. It can't grow much. There's all bone surrounding. Well, so when the 8th nerve will keep trying to grow, and if it can possibly do so, it'll push its way out into the brainstem area. So here's your 8th nerve tumor now. Because this tissue here is soft. It gives. And the whole brainstem, you can see, is bent, twisted. And look at how the person's 7th facial nerve is also affected. See? That's one of the other pairs of cranial nerves. So sometimes when a person has an 8th nerve tumor, he or she complains of facial tingling. They'll have other symptoms, okay? So it's not just always the 8th nerve that's affected. Now here's a picture of a large tumor in the IAM, internal auditory meatus. And that through that tunnel, you're going to have the 7th facial nerve, you're going to have the vestibular portion of the 8th nerve, another vestibular portion of the 8th nerve, and here's the auditory portion of the 8th nerve. Okay? And the tumor is this. And the tumor is now squeezing on that 8th nerve. Here's a picture of asymmetrical sensory neural loss. on the top. And it says the large difference between the ear thresholds requires a medical consultation to rule out an acoustic neuroma. Acoustic neuroma is a tumor of the eighth nerve. That's what physicians often call it, acoustic neuroma. Now, in this case, at the bottom, you can see that the hearing loss here, unilateral hearing loss for the right ear, the loss is mixed and moderate in degree. The conductive component here, can you see here's where the thresholds would have been. Here's where the masked thresholds are, and I don't think they're showing bone scores on here, but they should. And anyway, what they're trying to tell you is the loss is mixed. And so this loss is asymmetrical too and needs a referral to a physician, but for a different reason. It's probably middle ear pathology. But the upper one here is a sign of eighth nerve tumor, and that's a red flag. Out of Martin, your textbook in Martin shows an audiogram looking like this. And if you look at this audiogram closely, you can see the right ear is normal. Now, Martin has weird symbols for bone conduction. I don't know why he does these like this. I have no idea. But look at the left ear. All of a sudden, whoa, goes down. Strange, okay? Very, very weird, okay? Again, exemplifying a left acoustic neuroma. And read what it says. Although the hearing loss in the left ear is mild, word recognition is poor and gets worse at higher intensities. So look at the right ear. SRT is 5. That's in agreement with pure tone averages. They did speech at 30 dB only, and the guy got 100% in his right ear because his right ear is normal. Left ear, SRT, agrees with pure tone averages, average of 5, 1, and 2,000 hertz, so it's around 20. And then they did speech at 30 dB over the 20, like 30 dB sensation level, over top of his PTA, you know, like over top of his SRT, so they probably did it at 50. And here he got only 74%. That doesn't make much sense because the loss isn't that big. And then when they went louder, it got even worse. So it's like, oh, you've got what they call rollover. It's here's an audiogram I drew. Now we'll talk about rollover in just a second. We're going back to it. And have a peek at this audiogram. I've labeled this guy's name as uh-oh. Okay? And look at, he too has an asymmetrical sensory neural loss. So if you fill in with me, just for fun, what would the SRT be on this guy's right ear? Probably would be what?
0 or 5.
Correct. Left ear, what would the SRT be here?
Probably 20, 25, maybe 30.
Makes sense? Okay. MCL, what would an MCL be expected for the guy's normal right ear? Give me a guess.
50.
Yep, 50 to 60. Left ear, MCL might be a little bit higher, maybe 60-ish. Speech discrimination in the right ear should be 100%. In the left ear, if this was due to an acoustic neuroma, it should be bad. Okay?
I put like 75 or below.
Sure, yeah.
I was guessing.
What type of tympanograms would you expect?
Normal.
Correct. Totally, because there's nothing wrong with the middle ear. Okay? Acoustic reflexes, however, would likely be absent or highly elevated in the left ear. Okay?
I put absent or reduced. Okay, so
yeah.
I still
absent,
figure that out part.
Absent, or they would be present but at elevated loudness levels. That's one way you could put it. Either absent or present but at elevated presentation levels. And elevated means 110, 115. I think acoustic reflexes only go up to about 115. That's usually about the highest level that they go. They start at about 80, 85 and go up to about 115. So if you've got acoustic reflexes kicking in at 115, that's an elevated level. Okay? Now here's something I'm going to talk about because we need to concentrate a lot on this particular stuff here. Let's just for the sheer heck of it. Look at this. Medical tests are not perfect. Okay, and the arena where medical tests are really tested is in retrocochlear pathology, especially in our field. In other words, look at this, pure tone testing. Raise your hand when you hear the tone, or say the word cow, say the word tree. Okay, those are easy tests. You're testing peripheral sensory neural hearing loss. But when you're getting deeper inside and looking for signs and symptoms of tumors, then the tests are not all created equal. Some tests are better than other tests. And when you're looking at tests, look at two things: sensitivity and specificity. Sensitivity and specificity. Sensitivity is how good is the test at catching the disease. I'll go to your notes here and show you right where that's written as well, just so you see it.
Of course.
Okay, right here, top of page 2 in your notes. Sensitivity of a test, ability to identify the person who's got the disease. How good is your test at picking out the person who had the disease? Did it catch everybody who had the disease? Okay, it's a very sensitive test. However, it might be so sensitive that it's catching people that don't have the disease. In other words, to catch catfish, it's catching some dolphins as well. Shoot, you better let those get, they're getting caught in the net. Better let those go. Okay? On the other hand, specificity of a test, sentence 2 here, right where I'm highlighting, specificity of a test is the ability of a test to pass someone who doesn't have the disease. Okay? Ability of a test to pass someone that doesn't have the disease. Very few tests are 100% sensitive and 100% specific. Very few of them are. And when it comes to tumors of the 8th nerve, the worst tests are usually behavioral. The worst tests are usually pure tone, asymmetrical findings, poor speech discrim. Those are not great tests. They're not bad, but they're not the best at finding that the person's got the tumor. The really best test is an MRI. Go to the hospital and get an MRI. Boom, done. That's a gold standard. The test is completely perfect. It's 100% sensitive and 100% specific. We can talk even less cerebrally. Look with otoscopy in the person's ear. Did you see wax? Duh. That's a gold standard. Every time you see the wax, yep, that's the wax. The guy's got earwax. Duh, I'm looking at it. Gold standard. Okay? Very important. Let's look at now back to the PowerPoint slide. Disease present, disease absent. Where have you seen this before? Just like in acoustics when you learned about thresholds. Remember? If I gave you a 50 decibel tone and you had normal hearing, every time you heard the 50 decibel tone, you'd say, yup. And every time you did not hear the tone, you'd say, nope. So you would have all true positives and all true negatives. But now let's say I made the tone 5 dB instead of 50, 5. Now your whole face is changing. I mean, now you are squinting with Clint Eastwood. You're going, I think so. The whole thing becomes harder. So you're going to have true positives and true negatives, but you're going to have a lot of false positives. No, wrong, tone wasn't present. Or sometimes you're going to keep your hand down when the tone was present. Another error. Okay? And that's the same thing with medical tests. Same crap. If the disease is present and the test says yes, that's a true positive. If the disease is absent and the test says no, that's a true negative. But sometimes the disease may be absent and the test is going to show positive. And positive is a bad sign. It's going to say you got the disease. When you don't, false positive. Sometimes you might have the disease and the test passes you. False negative. Okay? Only if a test is true, if a test is sensitive, it gives all true positives, and if a test is negative, it gives all true negatives. But just because a test is 100% sensitive doesn't mean it's 100% specific. In other words, it might catch everyone who's got the disease, but it might also catch people that don't have the disease. Okay? And this is where tests of retrocochlear pathology can be tested. Tests can be tested. And I guess that's what I'm trying to say to you here. And let's look at what tests are pretty good and which ones are kind of frightening. Let's go up here, see if we got this puppy here. So we've covered some of these things. Oh yeah, look at all this. We're getting it. Look at that. All right. How common are eighth nerve tumors? Let's first look at that for a sec too. Eighth nerve tumors are not very common. According to Schucknecht, the guy who coined the different types of presbycusis, acoustic tumors comprise 8 to 10% of all brain tumors. 8 to 10% of all brain tumors. Martin says acoustic tumors appear at a rate of 1 per 100,000 a year. Now, how big is Springfield, Missouri? 250,000. How many people in Springfield, Missouri would have an eighth nerve tumor? 2.5. How big is Boise, Idaho? How many people live in Boise?
Oh, probably the whole area, 500,000.
There you go. You might have 5 people with an acoustic neuroma in Boise. Okay? So it's just Portland, probably what, 2 million people? Okay? You might have 20. Just it's very, so when people refer, it's not all the referrals don't come back with an eighth nerve tumor. Many of them just happen to have an asymmetrical loss. Many of them just happen to have the asymmetrical loss with lousy speech discrim in that ear. Okay? But you have to play it safe. You don't want to have false negatives passing someone that's got the disease or the person's going to die. So I'd rather have false positives than false negatives. But eighth nerve tumors will kill you. They are benign, but they will kill you. So you have to get them out. All right. Usually the initial symptom for an acoustic tumor is usually hearing loss, sometimes tinnitus, sometimes vestibular problems, a bit. Tumors can be tiny or greater than 2 centimeters. How big is a centimeter? Like your fingernail. Okay, so it can be like twice as big as your fingernail. They can get bigger. The size of the tumor, I would put a star by this. The size of the tumor has an effect on the test performance. The larger the tumor, the better the test will be at detecting the tumor. Well, that makes sense. I mean, it's just logical. And then you've learned now about true positives and all this stuff at the bottom of the page. We've covered that because we did that already. So we'll just kind of go over. Here's 2 words to put a star by. The validity of a test and the reliability of a test. The validity of a test is the accuracy of it. Does it test what it says it's testing? Does it test what it says it's testing? I'm going to give you an example of this, and I'll stop sharing for a sec. Audiologists do a test for central auditory processing. That means you're not testing the child's ability to hear. You're testing the child's ability to listen. Okay? They call that central auditory processing. It's often a test done for kids with what they call learning disabilities. Well, guess what? Are the tests for central auditory processing always very valid? Not really, because guess who fails them the most? Boys. Not girls, little boys. How come? Because their brains develop a little differently and a little bit slower than girls do. Girls learn to talk earlier than boys. There's whole different sets of language acquisition for little girls than there is for little boys. It's obvious that women are the superior sex. I mean, I don't know how you ever let men take over, because we die earlier. You know, when the winds blow, we snap like an oak tree. When, as we've said before, when the winds blow, women just bend like reeds in the wind. Anyway, the validity of some of these tests is called in question. Are they truly testing learning disabilities, or are they testing gender? See what I'm saying? Validity. I just want to highlight that just for you. Just reliability of the test. On the bottom of the page. That is, will the test show the same results on the same person again and again? It's a stability. So one is the test testing what it says it's testing, validity. Reliability is, will it get the same results again and again? We've covered sensitivity, we've covered specificity, we've covered gold standard, and now it's time to wind on down. Whatever we don't finish today, we'll cover tomorrow, but let's look at this. For retrocochlear pathology, eighth nerves is the biggest retrocochlear pathology, okay? CT scans are good, MRIs are the best. What's the difference between a CT scan and an MRI? I think tomorrow I'm going to show you. I think tomorrow I'm going to show you CAT scans and MRIs of my daughter's brain so you can see the difference, just for the sheer heck of it. MRIs have better resolution. MRIs show gray and white matter, the contrast, way better. CAT scans are okay, but they're kind of blurry. CAT scans are cheaper. MRIs are like a CAT scan on steroids, okay? And MRIs are the gold standard. CAT scans are next. And the next one is ABR. Now, ABR stands for auditory brainstem response. I'll show you what that looks like in a second here. And then acoustic reflex and acoustic reflex decay. You see why we took some tympanometry earlier in this thing? Because we're going to apply some of that when we look at retrocochlear pathology. I'll show you a picture, though, of an ABR, just for the heck of it. Here's a picture of an ABR. An ABR is done when they take, they put an electrode right here, right between your eyes. They put another electrode right on your hairline, and the one between your eyes is a ground. Then they put one electrode on this earlobe, and they put another electrode on this earlobe. So the guy's got 4 electrodes on him. 4. One's a ground, though. So really 3. One here, one here, one here. Then they put headphones on you. And in your right ear, out come these sounds. And each is called a click. I can make a sound like it. Here we go. It's gonna. And what you're going to get is an ABR. What happens is, and take a look at the top right, or here on where I'm circling, you're going to get 5 bumps. Peak 1, peak 2, 3, 4, 5. And they come from your 8th nerve and brain stem. 8th nerve, 1 inch long, brain stem, 1 inch long. And peak 1 comes from where your inner hair cells send info to your 8th nerve. Peak 2 is where your 8th nerve ends on your brain stem. So peaks 1 and 2 are 8th nerve. Peaks 3, 4, and 5 are for your brain stem, medulla, pons, midbrain. Now we're cooking here. And look at this picture. When they made it at 80 dB, those 5 peaks stood out like crazy. When they made the clicks 60, the peaks began to disappear a little bit. They got later and they got smaller. And when you made the sound 40, the peaks really began to disappear, and the only peak left was peak 5. And when they made the sound 20, only peak 5 existed. Now, can you see how the ABR might be a good test for babies? Because if you get an ABR, it means you've got hearing, at least for the pitch of those clicks, and you can go all the way down to 20 and you still had a brainwave. By the way, audiologists do ABRs, and audiologists take an entire semester course on ABR, auditory brainstem response. The ABR has 2 purposes. One is for threshold testing, as is seen on this PowerPoint slide. You can see right ear on the top left, left ear on the top right here. And in both ears, look carefully at this. As 80 turns to 60, turns to 40, turns to 20, you've got peaks all the time. Okay? That would mean this person's got normal hearing. But the other purpose of ABR is for tumors. Now look at the person's right ear. Yep, 80, all the peaks there. Bump it up. 60, most of the peaks there, just like in the previous slide. 30, yep, you still got a peak 5. Not bad. Look at the left ear. 80, whoa, the peaks look different. See how big and stretched out they are? And this is at 90. You guys, they're at 90 here, and the peaks are still kind of spread out. But where's the spread taking place? The spread isn't taking place between 3 and 5, because this spread is similar to this spread in terms of distance. The thing here, it's between 1 and 3. That's what's spread out compared to this 1 and 3. So we're going, you have an 8th nerve tumor. It's on your 8th nerve, because peaks 1 and 2 are 8th nerve. And your problem in this ABR appears at the early part, 8th nerve. These peaks are for the brainstem, and that's normal. Look at 60, or no, you're at 80, I should say. Everything's gone almost. At 70, gone. And the guy might have a mild hearing loss. His hearing loss might be like 20 dB, but his whole ABR is screwed. Okay? ABR is a very good test. It's quite sensitive, quite specific. It's not as good as an MRI, but it's pretty good. Okay? If we finish here, you're looking at, we'll just sort of read this here. MRI with gadolinium dye. Ooh, look at where that word is. Have you ever had an MRI done? If you ever get one done, they sometimes inject you with a dye. They put a needle in you. Now, when I had it done, it was for my throat. I had a terrible throat infection, and they injected my arm with that gadolinium. And I stopped the clinician, and I said, I think I just went pee. She goes, no, you didn't. It's the dye, but you're the first male who's ever confessed that. So most women tell us, but men never say it. But yeah, and often one of the side effects is you'll swear to God you just peed and you didn't. But the purpose of that dye is to increase the contrast between gray and white. It's to make the whole thing look really, really sharp. Anyway. A strange Zoom session this morning, huh? Anyway, and then as we read, it can detect small tumors, hit rates, which means true positives, true negatives, okay, are 99%. ABR has a true positive hit rate. Whenever you see the word hit rate, think true positive, and whenever you see correct rejection, think true negative. Look at ABR, it's pretty good, 95 and 89, not bad. Word recognition and tone decay and acoustic reflex decay fall well below. Now, what is tone decay? I'll tell you what tone decay is. Tone decay. They never use it anymore. They used it before CAT scans and before MRIs. When did CAT scans emerge? 1971. Okay, so you're talking old audiologists looking for an 8th nerve tumor. Here's what they did. They put 110 decibel sound in your ear. They'll pick 1,000 hertz. And you hold your hand up They're presented to that ear for 60 seconds. And you're supposed to hold your hand up as long as you hear that tone. It's like, why don't you stare into the sun for 60 seconds? You know, like, talk about causing noise-induced hearing loss. Stupid test. Well, their thought was, if you have an eighth nerve tumor, the nerve is going to get tired of carrying the message, and you're going to put your hand down because you won't hear the tone all 60 seconds. Now, can you see how that's not as sensitive and not as specific? Okay, same with word recognition. Say the word cow, say the word tree, say the word butt, say the word cup. Okay, you might catch a person who has the tumor that way, but the sensitivity and specificity don't come close to an MRI. Get it? Good.
Can you see hair cells in the MRI?
No, that's a great question, Kelly. You can't. You can see the turns of the cochlea, though. Mm-hmm. You can see the 2.5 turns of the cochlea, but you can't quite get in and see hair cells. Not quite. No. That's why otoacoustic emissions that are written about in your inner ear pathology notes are a window into an otherwise inaccessible cochlea. They really are. It's any other questions, though? We've gone on perfect. This is our time. We've done 1 hour here. Tomorrow morning, I'm going to finish off this, which we've basically mostly covered, and I'll touch on pseudo-hypoacusis, malingering, which isn't a disorder, physical disorder, but is a mental disorder. Okay? A good way to finish off hearing disorders.
How many people do you estimate that you've seen that are pseudo?
Very few, but you know what? When you get them, Kelly, it for some reason makes your blood. You know what I did by mistake one time? And there's ways that we can tell the person's lying. I forgot, you know how you have the interrupter button on an audiometer? I forgot to turn it off. I leaned back in my chair. Hey, Sharon, we got ourselves a liar here. And the person didn't flinch. He was good. He pretended he didn't hear me. Like, he was good. He was, but he was faking it. We said, I said, well, tomorrow we're going to have you in and I'll do brain waves on you. You know, I was going to do an ABR on him. Because ABRs don't lie. But of course, he never came back.
Was it for work, like to get work?
Usually workers' comp. There's two populations that like to malinger. 64-year-old males and 9-year-old boys and 11-year-old girls who are just reaching puberty. And they want attention. They feel lousy about themselves in front of their peers, and they want a problem and they want a disorder. I was one at age 9. I faked hearing loss.
Me too. Oh yeah. Well, I tried. She figured it out. But
yeah, they figured it out. Okay. Well, we'll talk next. We'll talk tomorrow. Are you going to join us too, Megan, or what?
Yep, I'll be here tomorrow.
All right. As we say, live long and prosper. All right. Adios. All right. End record.